Good evening, friends. We'll just discuss about the dental implants. Why and when you need a dental implant treatment. When it is necessary for you to go for dental implants. Is it compulsory that you have to go for dental implant treatment only to get your fixed teeth? Or is there any other options you can go for? If there is a failed root canal tooth, or if there is an extracted tooth long back or in the recent times, there will be an edentulous space because of extraction or because of extraction of failed root canal tooth with the crown maybe. So there will be an edentulous space which has to be filled. That gap has to be restored with the tooth. Otherwise, the adjacent tooth will move towards the empty space, or the opposing tooth, if the missing tooth is in the lower, the opposing tooth will come down, or if the missing tooth is in the upper, the lower teeth will be shown above the occlusion level. So there is a need for replacement for a fixed teeth. Suppose if you have lost two anterior tooth because of periodontal issue, or because of failed RCT, or because of trauma, or because of some accident for which the tooth has come out, it's avulsed. So what will be the next step to get the fixed teeth in that particular anterior teeth? You can go for the fixed partial teeth by taking the support of two adjacent good teeth. So those will be the abutment, and you are going to replace the pontic. So the total it will be 4 units. Why you want to go for 4 units of the crown when you have lost only 2 teeth? There is no other option. You have to take the support of the adjacent teeth to restore the missing tooth structures. So you will take the support of adjacent teeth, right? So now in implant dentistry, what we follow is we are going to replace the tooth only in the area where the tooth has been lost. Means we are not going to touch the adjacent teeth for any reason. Okay, so we are going to place the implant only in the missing area. So the adjacent teeth which are good, they will remain good. We are not going to reduce the tooth structure of those. So implants will be placed only where there is a missing tooth. If one tooth is missing, we'll place an implant, upon that will give crown. What kind of implants is necessary for you, that the doctor has to determine. Suppose if you have lost the tooth few years back, that space is empty for longer time, now you want to go for the fixed treatment. Suppose your age is 25 and you lost the tooth at the age of 22 and you left it like that only. Now it's in the aesthetic zone. It's important. Maybe the patient's marriage is there, whether it is a male or female patient, she has to go for fixed kind of teeth to replace that missing tooth, so that her smile will be restored, and her confidence to talk in front of anyone, or her confidence to boost her confidence level. She needs a fixed treatment. In such cases, being an implantologist, my plan is what is the need for that particular patient have to go through. So how will decide depending upon the X-rays which I advise the patient to go for. I will see the length of the bone in OPG or CBCT. It's a tomographic radiographs. So I will assess the type of bone in that area, whether it is a D1, D2, D3, D4, what kind of bone. Usually in the anteriors there will be a good D1, D2 bone in the lower, and also in the upper anteriors there will be a good D1, D2 bone for that particular patient whose age is 25. Right. So we are going to decide which kind of implant you are going to place. Suppose I was a conventional implant practitioner for a long time. I used to practice conventional implants. Now also I practice conventional implants sometimes. But the thing is, if you place a conventional implant, if the patient is in a hurry for the treatment, after placing the conventional implant, you need to wait for 3 to 4 months for osseointegration of the implant to the tooth structure. So osseointegration takes place in the first 20 days, 21 days of healing period. So totally you need some more than 8 weeks for integration. Then again you have to take an X-ray and you have to check the stability of the implant through the oral examination. So if everything is fine, torque is fine, stability is good, then you can go for the prosthetic part, wherein you are going to check the abutment height, everything with the opposing arch, and then you can give the screw retained or cement retained crown on that particular conventional implant. But all these procedure will take 3 to 4 months. So I used to do all kinds of conventional implants. I was having the regular practice of conventional implants for so many years. But the problem is the patient never used to wait. The patient won't be having patience to wait till 4 to 5 months. Sometimes in one case where in the lower left first molar have done the extraction and placed the implant. That was an immediate placement of the implant. So since I was not happy with the stability of the implant, I used some allograft and placed the membrane also and closed the suture and then waited for 3-4 months. After 4 months, I just called up the patient and sent him for X-ray and evaluated the X-ray and came to know that the stability is fine. So I started doing the prosthetic part and gave the crown also. And I asked the patient to not to tighten that part. It was on the left side in the third quadrant for a few more days. So patient followed whatever the instructions have given him. The patient came back after 3 months. The problem was it was mobile. The integration was good in the X-ray. Everything seems to be happy, but the patient came back with the mobile tooth with the implant. I just checked it. The implant. What was the reason? What was the reason for the failure of the implant in this conventional technique? Was my technique was bad? No, I followed the protocol. I placed the implants and I was knowing that stability was not good, so the grafts and membranes were placed and suture was given, and there was no peri-implantitis around the surface of the implant, but still implant failed. So what is the reason? Patient was not diabetic, and patient was not undergoing any kind of immunosuppressive drugs, was not taking, and what is the reason for the failure? Maybe the reason was the bone, the cancellous bone, which is below the crust of the mandible, which is below the crust of that is, first is the crust and below this is the cancellous bone where this conventional implant engages. Maybe that cancellous bone was weak, that we cannot assess in the radiographs. Only by doing your drilling technique only we'll come to know what kind of bone it is. Okay, that is the density of bone. It's not completely assessed out of the radiographs. Only which has to be correlated with your oral surgical techniques. So that bone was maybe trabecular pattern was coarse, and there were the bone which was present was maybe some D3 or D4 kind of bone. That is one reason. Maybe after the placement of the implant, patient did not follow the instructions given to him, and maybe other few more contributing factors also. Patient was a smoker too, but he was not diabetic. It's failed. So, and then it's not easy to tell the patients that if you call the patient after 3 months of placement of your conventional implant, take an X-ray. If you're not happy with the stability, you'll ask the patient to wait for 2 more months. So during that time, patient will get agitated. The patient will go, he will call and come back, or otherwise will talk to you in phone. So how long it will take, doctor? It's already 5 months. How long should I wait? So all these few drawbacks of conventional implants. And then I thought of some kind of treatment wherein the patient's treatment should be completed in a short period, and the treatment types should be a pinhole kind of, less comfort to the patient, and the patient should start using the processes whichever we give from the day one or earlier, from maybe from the second or third day of fixing up the processes. Then I come across cortico-basal implants. These cortico-basal implants, I was not knowing about these implants. I used to go through some research works and some papers, some articles which I have read on basal implants. I have read some articles by Stephen Ide and a few more authors. Then I started reading and started thinking about practicing the basal implants. Once when I started doing these basal implants, even I was having the dilemma that what will be the outcome, what will be the results of these basal implants, how long it will last. So what are the types of implants are there in basal, and where we need to place the implant, whether it should be placed in the cancellous bone or the cortical bone, where exactly the cortical bone lies. All these confusions promoted me to do some more research on basal implants, and I have attended a few courses on basal implantology. I have gone for some 7-day course and the 3-day courses, all those I have attended. Then I started practicing basal implants. So usually the basic of basal implantology compared to the conventional implants is, where conventional implants you are going to place the implant below the crust, that is in the cancellous bone. The crustal bone is hard, cancellous bone is not that hard. Below that, the cancellous bone, there is one more bone, that is the cortical bone. That bone is hard. The cortical bone will be present below the cancellous bone and it will be hard. You have to engage the basal implants in that cortical bone. The concept here what we use in corticobasal implantology is osteofixation, or osteofixation then followed by osseointegration by secondary intention. Even osseointegration also happens by secondary intention. The main focus is osteofixation should happen, which gives the good primary stability. So during the initial stages, I used to do the partial peduncular spaces in the lower anteriors, in the lower posteriors. I have placed few implants, that is BCS, basal cortical implants it's called as. There is one more type is also BECS is also there. There is extended version of the BCS implants. BCS implants will have only the few threads. BECS extended version will have more threads. Okay. These BECS and BCS implants, where you have to place, that should be explained later on. So then when I've completed my first case in the lower anterior, I gave, I think it's a 3-1. It's an extracted site, and the patient, it was an edentulous area for a long time for that particular patient. So I asked the patient to go for the OPG, and I just measured the length of the bone up from the crest till the base of the mandible. It was around 26 mm. So if there is a 26 mm of bone is available to place an implant, I should engage the implant deeper. In that particular place, I engaged the implant till 23 mm. I placed a 23 mm implant in that area. Upon that, I kept the pin. Till today, the patient has not come. That was my first case, and the patient is very happy. No issues at all. And moreover, all the basal implants are the smooth surface implants. The chances for peri-implantitis or any other kind of infection or the microbial accumulation, all those things will be very less compared to the conventional, where is the conventional will be rough surface implants. There will be chances sometimes for the peri-implantitis to occur. Okay, in smooth surface implants it's very less. It will not happen. Then I started doing the partially edentulous areas in the third quadrant one case, and then initially I used to do only the partially edentulous areas only. Starting. Then one of my friend, he got a case where the patient was using the dentures for more than 18-20 years. Patient already used 2 sets of dentures. So we plan to place the implants for the whole mouth. Then we have to assess how many implant we are going to place, how many implant in the upper, how many implant in the lower, and what kind of implants we are going to place. All these things should be properly evaluated. The treatment plan should be planned in a proper way. So I sent the patient for CBCT. So wherein we came to know that the maxillary area, it was completely atrophic maxilla, and the sinus on both the sides was almost near the crest of the ridge. Not even 4 mm or 5 mm bone was there to place the conventional implant, either through a direct technique or the indirect technique by opening the wall on the lateral side. So it's not at all suitable for the conventional type. Bone was very big. If you drill 2 mm, 3 mm, your drill will easily go inside the sinus. That was the kind of the bone. It was completely atrophic maxilla. Now we have to place the implant in the area anterior to the maxillary sinus and posterior to the maxillary sinus. If you are going to place anterior to the maxillary sinus, where are you going to place? You have to you have to always cortical implant should be placed deep inside, where the cortical bone is available. Till that area you have to engage. You have to perforate that area and place. So in the anterior, we have to perforate the nasal floor and place the implant in the anterior region. You start from the central lateral canine on the left, central lateral canine on the right. You place 6 implants. If those implants are firm, which gives the primary most important stability for your upper prosthesis, then if you are not going to place the implant between the second premolar and the second molar area, above that where the sinus is available, you have to place the implant in the tuberosity area or beyond the tuberosity area, medial to the hemular notch, towards the hemular notch, which is that good bone available there. The only good bone available in that area is between the lateral and the medial pterygoid. Okay, so you have to engage that area. There are different techniques to engage the pterygoid implants in that particular area. About the pterygoids only, we will discuss in the next video. So pterygoid implants, you can place two pterygoids, double pterygoids we call it as. So you can place lengthy implant there, that is 20 mm and 23 mm depending upon the excellent availability of the bone there. So upper pterygoids on both the sides, anterior 6 implants, totally placed to 10 implants we have placed, right? In the lower, for that particular patient which I told, it was my first case, lower also ridge was not that good, but bone height was there a little bit. But the problem with the lower mandible is the vicinity, or where is that mandibular canal in the mandible, so that you have to properly diagnose, and you have to take the measurement from the crest till the superior border of the mandibular canal. And more important area in the mandibular implant placement is you have to take very much care in the mental foramen area, that is between the first premolar and the second premolar, where there will be mental foramen. That area should be careful. You have to better to avoid that area to place an implant sometimes, if in the complete edentulous case. So if you have confusion, leave that area. Same holds good for maxilla also. In that maxillary sinus area, don't place any implant in the full mouth. In the lower also, don't place any implant between first premolar and second premolar. Or in all other areas, you place the implant. So lower also, you have to place some 6 to 8 implants, and in the processes which you gave for the in full mouth cases, you can give the hybrid denture, or otherwise you can give the fixed processes with the PFM crowns, or you can give DMLS crowns, or you can give zirconia crowns also. For full mouth, no issues, nothing goes wrong. Okay, so this is the tech what we follow in the full mouth case. For example, if you don't have, or otherwise, there are such instances wherein you cannot place the BCS implants. For example, mandibular posterior area where the first and second molar is there, you cannot place the BCS implants. BCS implant will not engage sometimes. There I started using the compressive implants. Compressive implants, surface treated implants. Those compressive implants will be the same as the conventional implants. The only thing is it's a mono implant, single piece implants, where the conventional will be 2-piece implant. These compressive implants will be having for the full length of the implant, or the threads will be there, and it's a surface treated. This engages really well in the posterior mandible. I prefer these compressive implants in the posterior mandible, mono compressive implants in the posterior mandible, and also in the pterygoid. In pterygoid, I used to place vampire implants also. Vampire is a kind of implant. I was using a system by name Bonankar. They were having good vampire implants. Vampire implants really good. The design is good to go, just to place it in the pterygoid plate. So you have to choose which kind of implant is good for that particular area. But the best for all the areas, BCS implants, you can place in all the places. You can place it in the nasal floor, you can place it in the upper premolar area, you can place it in the tuberosity of maxilla, you can place it in the anterior mandible, you can place it in the molar area on both the sides. You can place it all over. BCS, universal, that is. BCS implants can be placed. You place no confusion at all. But you have to determine the length of the implant depending upon the available bone, and your determination of length depending upon X-ray. So that is one thing. So apart from BCS implants, there is BECS implants, that is extended threads will be there in BECS. These implants are very good in immediate extraction areas. If you have extracted one particular tooth in the molar area, you place BECS. It's really uh, you will get a good stability, primary stability, and the torque will be good. BECS for immediate extraction cases. Okay. There are instances apart from the first case, another 4-5 of my in another second. I think it's in the fourth or fifth case of my full mouth. Have placed in all the places. Have placed compressive implant. All the places have placed compressive implant. So it's been almost 2 years that patient is doing well. So the main thing is BCS, where you want to engage the corticals, BCS, where you want to engage the BCS lengthy implants in the zygoma engagement also. BCS is good. Zygoma engagement, BCS is good. Bioline has got good 40 mm, 38 mm, 40 mm, 50 mm. Zygoma bendable mono implants. But we have used Norris 2-piece implants, zygomatic implants of our one mycosis patient, because we could not place bioline mono for that particular patient. So we used 2-piece Norris zygomatic implants for one mycosis patient. So that is the thing. So single piece mono compressive implants are really good. Different companies will have different design, pattern, diameter, all those things. But I am happy with Bioline compressive implants. They are too good. When you go for BCS implants, I have used Simplodent, BCS Simplodent. I have used BCS Bonanker. I have used BCS some other few companies. All those are good BCS, but compressive, I'm happy with Bioline. It's really good. So this is the thing. Whether it is a full mouth case or when you want to restore the one single missing tooth, or one or two teeth missing tooth, you have to plan properly. Planning is very important for the success of your implant treatment. The X-ray will give you a brief idea about the kind of bone, whether you are doing the full mouth case or a single tooth replacement. The bone what is available is important. The X-ray will give you a brief idea, followed by your oral examination and your initial drills for in that particular place will give more idea about the kind of bone available. Okay, so this is the thing, initial basic steps to be followed. Main thing in basal implantology is you have to be thorough with the anatomical structures. The most important anatomical structures are mandibular canal, mental foramen, maxillary sinus in the upper posteriors, and also in the lower anterior, anastomosis of the lingual arteries. Sometimes in the lower anterior region, if you drill more towards the lingual, there will be more and much bleeding will be there. That is because of lot of capillary arteries from the lingual artery. Those are the branch of lingual artery. In that area you have to be careful. Nothing goes wrong. Bleeding will stop. Apply some hemostatic agents. Bleeding will stop. No issues. Only thing is your concern areas are the mandibular canal, mental foramen, maxillary sinus, and in the pterygoid area there should not be much angulation towards the hemular notch. If you drill more towards the hemular notch medially, there will be infection and inflammation of that particular area, and the swelling will be there. Okay, so that you have to keep it in mind. These are all the main thing. Main thing is assess the kind of bone and the drills which you are using to use, and the kind of implant you are going to place. You are going to choose and decide which implant suits this particular area, this particular region. That we have to determine and assess properly. Okay, so we'll discuss more things in the next video. Thank you so much.